Done, sir.
Prashant, your voice was breaking in the last few sentences.
Yes, sir. Yes, sir. Is it clear now, sir?
Yeah, it's clear. It's clear.
Yeah. All right. Good evening, everyone. On behalf of NNF Karnataka, I would like to welcome all the speakers who have been joining us and all the delegates who have been sparing time. Today, it's really an exciting. It's going to be an exciting webinar session because we're going to talk on the latest updates in the technology, integrating the technology with the medicine is what has been done, and today's topic is all about that. So we have three wonderful speakers, Ms. Hila Friedmann, Dr. Shoshna Haberman, and Dr. Kishore Kumar. On behalf of NNF Karnataka, a warm welcome to all of you. And for today's session, we have panelists, Dr. Leena, Dr. Megha, and Dr. Prakash Mehta. Welcome, sir. Welcome, ma'am, for the NNF Karnataka web session. So we are covering today the most important and the latest topic of integrating artificial intelligence in predicting the high-risk pregnancies. And as we know that prevention is always better than cure, preventing high-risk pregnancy, preventing premature labor and premature delivery is something which can reduce the infant mortality rate. A dream of single-digit infant mortality rate can only be done with prevention. And today we have a wonderful session which will be starting. I request Ganesh ji to introduce our speakers to the audience. And then I request Ms. Hila Friedmann to start the session. Over to you, Ganesh ji.
Good evening, Dr. Prashant. Good evening to all. I think it's going to be a very, very important session. I think a milestone in maternal and newborn care in our country. It's my privilege and pleasure to introduce Ms. Hila Friedmann, who's a seasonal entrepreneur and CEO and co-founder of Gynisus. Ms. Friedmann graduated in biomedical engineering of magna cum laude from engineering school at Tel Aviv, Israel. She is a certified data scientist at Stanford. Ms. Friedmann is also a part of AILA Community California University and in the prestigious program in biodesign in Stanford University. Prior to establishing Gynisus, Ms. Friedmann served as leading leading business and product development and a knowledge engineer at Siemens Healthineers. I think it's a privilege to introduce Dr. Hila Friedmann, and over to you, Hila. We look forward to hearing from you on the latest advances in AI and how anywhere in the world, especially in US or Europe, where it's already being practiced, we are already seeing great outcomes, and we are very happy to join hands with you to launch this to our neonatologists, obstetricians, and pediatricians in our country. Over to you, Hila.
Thank you very much. Thank you very much, Ganesh. Thank you very much, everyone, for joining this session, especially on Sunday. I have the privilege, to join forces with GenWorks, which is very promising in order to bring this technology and to leverage it to solve all these things around healthcare, regarding the clinical and financial implications. I will start, just 1 second, let me share my screen. Please confirm that you can see my screen.
Yeah, we can see your screen.
Perfect, thank you. So as Ganesh started and mentioned, myself, I am a biomedical engineer, a physicist and data scientist. I've been working in this space 14 years now, started from cybersecurity and moved to the healthcare space 12 years ago. And basically we established Gynisus based on a personal story of my professor, where she suffered from several medical incidents. I would say that all of them have started from misdiagnosis and ended, unfortunately, in complications. So therefore, she encouraged me and joined me, and together we established Gynisus. And our main goal at Gynisus is to change the way that people are diagnosed and treated by predicting disease at the pre-existing conditions. And that means that, as you started and mentioned, it is very important to start or to recognize these potential conditions that are about to be happening in the nearest future or in the longest future, in order to be able to prevent them, and instead of trying to cure them. So we are focusing on two main burdens around the healthcare. So the first one is around the clinical implications, that we all know that all these financial clinical implications, the majority of them are predictable and preventable. So these medical errors that we are talking about, and all these medical errors that at the end of the way are leading to some complications, we are talking about on a really significant problem, that in the US, for example, we are talking about a problem that is leading to $800 billion every year, sorry. And in India, we are talking about 5.2 million cases that are preventable cases. So if we focus on specifically the pregnancy outcomes or maternal neonatal complications, in India there are 3.5 million preterm deliveries every year. And these incidents are of course leading to some clinical and financial implications. These implications are starting from misdiagnosis and are ending in these complications. They are leading also to hospitalization days, or many of them, and prolonged stays and admissions to the NICUs, and not to mention, afterwards the implications that will be for the newborn and its mother, or her. And then all these clinical implications are, of course, associated with many financial impacts. So as you can see here, we are talking about $37.8 million that are just spending in India for the NICUs. So all these complications that first are preventable even before the pregnancy, and I will explain a little bit about it in a few moments. And also, even after we have this preterm delivery, there are few ways to handle with these situations in the NICUs in a much more precise way, in a way that we can prevent this future deterioration. Okay, so I had the privilege to actually handle with this amazing opportunity of AI. And as I started and mentioned, on almost my whole professional life, I'm working in the artificial intelligence space in different verticals, but in the main vertical, which is the healthcare. So I would like now to take you to this journey together with me, and to explain you and to provide you a little bit information or an idea about the topic that named AI. And if we are talking about a revolution, so definitely AI is one of the amazing revolutions that we are just starting and see. But I believe that it will be just going larger and larger over time. So what is basically AI or artificial intelligence? So when we are saying AI, mainly we are talking about machines that are programmed to think like humans and mimic their actions. And it can be different things around different fields, and this scope is pretty broad. But in today's talk, I'm going to focus on the healthcare space. So there are several types of AI, which I will walk through really briefly, so excuse me about it. The first one is the supervised learning, then we have the unsupervised learning, deep learning and neural networks, which is definitely the same. And then I will come to the most promising space, in my opinion, which is online and reinforcement learning. So let's start. So when we are talking about supervised learning, we are talking about sorry, someone has a question? Okay. So I would like to kindly ask you to mute yourself so then we can go through everything fluently. Thank you. So the first section that I'm going to talk about is the supervised learning. In the supervised learning, we have data. It doesn't matter which type of data. It can be data that was coming from the EMR, or it can be data that is coming from the CT scans or the MRI scans, as you can see on the right side of the screen. And in this data, we are collecting the data and we are labeling this data. So with these labels, we are using them in order to teach the system what is normal and what is abnormal. Okay, so here is just simple examples of HCC. And here is another example for normal healthy liver. Okay, so what we are doing is, as I mentioned, we are collecting this raw data. It doesn't matter if it will be any of these data types that I've mentioned. We have our labels that shows us whether it's healthy or not. In this process, the algorithm will learn what are the patterns that returns in the data that of healthy images or other data types, and what is abnormal. And then after this process, we will receive all these things, which we call classifiers, which are different groups of different labels. What it means, so the red here can be HCC, and the green here can be the LT liver, and the third one can be different type of cancer. Okay, so different classifiers. Moving on to unsupervised, moving on to unsupervised learning. As I mentioned before, then supervised learning is just one second. Supervised learning is the learning that we can that we do have the labels, which means that we do have someone which can be physician or other people from the medical staff label this data, and they recognize what is healthy and what is not. In unsupervised learning, it is the opposite thing. We are providing the machine different, it can be different images, it can be in this case you can see here that we have cats and dogs, but it can be the HCC that I showed before then, and LT livers, meaning LT images with LT liver, and other examples like it. The first thing that we are doing is to recognize the pattern. The second step, to provide the uncategorized images or data. The second step will be to recognize these patterns, and based on these patterns to make these predictions. So there are two main types of this thing in the healthcare space. The first one is clustering, where we want to find similar things. Okay, so similar groups or a big group can be cancer in general speaking, or we can drill down to the specific cancer that we want to find in the image or the signal or other data type. The other one will be the anomaly detection, where we want to find what is abnormal in the pattern. Okay, so we have healthy pattern, or we have the majority, and in the medical space it is pretty straightforward because the majority of the people are healthy, and therefore it's pretty straightforward to use such technology as anomaly detection, because we have a lot of examples of healthy people. But if something is out of the range, or if something is abnormal, then we can detect it pretty easily. And I will give you just a simple example of the ECG patterns, right? So this one is an unlabeled ECG with arrhythmia, and what we'll do, we'll take all the images of ECG, or the signals, or the raw data itself, and based on these images, or based on the signal itself, we will detect the regions that we found to be abnormal, that are going out of the pattern. On to the deep learning neural network, I think that this is the most famous one in this space so far. So I'm pretty sure that all of you have heard of neural networks and deep learning, and they are pretty much exactly the same thing. And the idea behind it is exactly to take the structure of a typical neuron of our brain, to mimic the work of our brain, or to mimic the way that we are thinking. I have to say that is way far from from the way that our brain is working. But that was the idea. So that's exactly what we have done here. So you can see here that the inputs are the dendrites, and the weights are the exons, right? And actually we sum it up, and then we decide to what, based on the weight, we decide to which information, or based on which information we are going to make the decision. Again, it's really in high level, but this is the idea behind it. There are different structures of these neural nets or deep learning, but simply the only difference between them is just the structure of the neural network. So deep learning neural nets are exactly the same thing. And how it works. So I will give you just a simple example of this process of how we train a neural network and how it works behind the scenes. So the first thing that we are doing, as always, we are providing the raw data. The raw data can be everything. The majority of the work that I've done so far using deep learning and neural nets techniques was on images. So that's the reason that I brought this example. So we have here different animals as an input. So it can be, here it's animals, but it can definitely be different, images like MRI scans, CT scans, ultrasound scans, etc. So what we are doing is to train these models. And how we train these models? The first layer will be just the edges. So we are detecting the edges. It is very high level, and we just looking into the edges. Afterwards, we are starting to recognize organs. And in the top layer, we are starting to connect all these findings that we have seen in the layers before to make a decision about the output. And this is exactly what you can see here. So it's 10% wolf and it's 90% dog. In this case, we are going to make a decision based on the last layer or the top layer, and actually what we have defined to be the threshold between being dog or detecting as a dog or detecting as a wolf. And this is exactly what we are doing with examples like brain scans. So it can be the threshold, what is this stroke or what it is not, or what it is COVID on CT scan and what is not. And if we will take X-ray, what is pneumonia or what is not pneumonia, etc. So these fine-tunings are very important to make sure that we don't have a lot of false alerts on one end, but on the other end, we don't want to miss important data. And the last one, but as I mentioned before then, I think that it's the most promising one, is the reinforcement learning. And here is how reinforcement learning works. So we have, again, our input raw data, which can be the same things, EMR data, lab tests, genetic data, images, etc. And inside this process, we have an agent. This agent is giving rewards or penalties to the algorithm. And what it means. So for example, in the real life, what we are doing as babies, right? So we are starting to walk, or we are starting when we learn how to talk. Someone is actually helping us by giving us continuous feedback. This feedback is our best way to learn. So that's exactly the idea with the reinforcement learning. We are starting from a baseline, we are providing these predictions, and then we are giving the model continuous feedback. Using this feedback, the algorithm actually fixing itself until we have the final output. And this final output can be based on the developer of the algorithm. So I will give you one example. If we decided that we would like to reduce the diabetes chances, okay, by providing medications, what we will do, we will decide that, for example, if the patient reached 100 milligram per deciliter, it's fair enough, let's say, for us, and we can stop this process. Otherwise, we will keep providing recommendations that will lead to reduce in the diabetes levels. So this is very important, and it's very important that the developer that is dealing with such problems in the AI space will be very familiar with this space in order to provide the right direction to the models. And this is very important part. I'm going to touch it a bit later in a couple of moments. So what can be, after all this explanation, what is the impact that artificial intelligence potentially, because now it's still building itself, I would say, in the healthcare space, and I really have the honor to lead our company, to be one of the first companies that really step into different spaces in the AI and the impact that on the healthcare. So the first thing, it's a more precise decisions, of course, because as I mentioned, the system, the algorithm has the capabilities to see thousands of different data elements, not only on the patient that you see at the moment, but on other patients, which for us as human beings will be very challenging or just impossible. So with this, going through all the data that in the system and all the data that I've analyzed on hundreds and thousands of patients, we can have a more precise decisions. So I want here to quote Dr. Golden that is saying the more accurate we get and the sooner we get to the right diagnosis, the better we are going to be. That's what digital pathology and AI has the opportunity to deliver. The second thing, as I mentioned before, then reduce, of course, misdiagnosis and complications. And here is the reason. If we are providing what is the likelihood that each of these patients will develop, or not necessarily patients, or each of these people will develop any of these conditions, then we have the opportunity to intervene early and prevent these incidents. So just one example that is pretty straightforward. We would prefer to recognize that someone has BRCA, BRCA gene in order to prevent future breast cancer than to start doing these interventions when the patient is already at cancer stage 4. So this is pretty straightforward reason. And of course, when we are starting these interventions earlier, then we are preventing also the complications that will be due to these misdiagnoses or late diagnosis. The third thing is revealing hidden areas in the data and solving enigmas. So far with the tools that we had, we reached actually the top of the humanity capabilities. So now with the AI and the possibilities, again, to see all the data, to see all the different interactions, and to walk through this, we have now the possibility also to solve enigmas. And one of them, of course, it's the preterm delivery that still nowadays it's an enigma. Again, I'm really honored to have this opportunity to be part of this company that is actually opening this black box using these tools. The fourth thing is, of course, improved decision making, the same as I mentioned before. So since we have the capability to diagnose early and to diagnose in real time, and to make sure that we are not missing any of these points, it is improving also the decision making and make it more precise. The fifth thing is automation processes. Of course, that we are leveraging the artificial intelligence to automate these processes, and by doing so to reduce the cost. The machine, it's like a manufacturer. The machine is keep working, and we can make sure that all the processes are automated, which is very important in the medical space especially, and I will touch it in one moment, because as we know, there are different, of course, physicians, and each of them are doing different decisions in the same identical situations. Which lead to challenges around making decisions in the future. I will mention it in a moment. And of course, as I mentioned before then, it has the opportunity to reduce misdiagnosis, complications, and hospitalization days and readmissions. And final thing here is that it has the possibility to expanding care to rural areas. So unfortunately, we don't have, neither in the States and also in India and in other places, we don't have the specialists everywhere. And with artificial intelligence that have learned, algorithms that have learned everything from the best practices and so different populations on on diverse populations, actually, we can take this technology and bring this care to everywhere. And after all, just to summarize all these advantages, it saves life, time, and money. So what are after all these great things that I've said about AI, and definitely there is huge potential in this space, we need to be aware of several challenges, specifically in the medical space. So the first thing, as we all know, there are a lot of unnecessary medical tests, which are leading to sparse data, and I will explain both. So all of us, or all over the world, we have different medical tests that are recommended for different situations. But at the end of it, each of the physicians or the medical staff may make a decision based on their understanding of the situation. And for example, let's say that one of the physicians send the patient to CBC test, just a simple lab test, and the results have returned with abnormality within the WBC, white blood cells. So now there are a lot of options as what to do next: to send this patient to an additional lab test, to send this patient to imaging tests, to send this patient to, again, additional tests from different types, hospitalize these patients. There are a lot of possibilities here. That leads to the situation of sparse data. And what is sparse data? When we have one patient, and this patient, let's say, diagnosed with gestational diabetes. So we have patient A, and now we have patient B, and patient A and patient B as different, totally different lab tests or other tests as well. So, for example, for patient A, we have different 100 tests, and for patient B, we can be in a situation that they have almost nothing, or maybe just demographics data or some of other, medical tests. That lead to the situation that we see really different picture on the same or around the identical situations, which led me to the third point, which is strong dependence on diverse decisions in identical situations. As I just explained, there are different decisions that physicians are making in identical situations that lead us to the issues that I just mentioned before. And the fourth thing, that we have biased decisions based on specific history. So if we have a specific picture, then it is making us to go in a specific way, and actually biasing the decision making. So these are all the challenges, or some of the challenges, but the most or the largest challenges of AI in the medical space. I would add even one more thing around them, that is the way that we are collecting data in the medical space, that is definitely different from other spaces. So this is all about the challenges. So what about the current status of the AI in the medical space? So right now, the majority of the companies or the methods and the algorithms that are being used in the medical space are more for detection. And I know that it might be, or it may be pretty confusing, the use that, you know, companies or individuals in terms of that are using in terms like detection or prediction, which is two different things. Detection is our capability to recognize something from the image, from the signal, from the lab test, etc. Prediction is our capability to see what is the likelihood that this patient will develop this disease in the nearest future or in the farthest future. So these are two different things. Detection are more aligning with the current medical space, where we are seeing patient and we are detecting specific disease at the right moment. Prediction is more like screening tools that are telling us what is the likelihood that this patient will have this specific diagnosis. So what are the main methods that are in the medical space currently? So the first one is the rule-based model. What it means, for example, if someone is obese or has high BMI, that means that they will develop hypertension, or they have high likelihood to develop hypertension, for example. We have also imaging and computer vision techniques that I'm sure that you all heard of, you know, detecting different disease over these images, like detection of stroke on CT scans, or detection of pneumonia on X-ray, or detection of COVID on CT scans as well, on MRI. There are a lot of techniques around it. The disadvantage of these techniques, again, is that they are seeing, or they are detecting only what they see. That means that only if something is on the image, meaning that it is already there, just then they will detect it, but they can't recognize something behind the scenes. So it's a great tool for automating things, but it's not helping us in the prevention or in the preventive healthcare. And the third thing is the same, but just for digital signal processing. So as I showed before then, we have an ECG signal, and through this on this ECG signal, we can detect anomalies like arrhythmia or MI, etc. So what we have done in this space that is different from what we have currently in the medical space in general speaking. So I would like to divide our SPY platform to 5 different sections, and I will now associate everything that I just explained before that regarding the different types of algorithms that we have under AI to what we are providing here. So the first thing that we do is a more precise diagnosis. As I mentioned before then, the first thing is that we have unfortunately, a lot of misdiagnosis. That can be due to this sparsity within the data. That can be because of we have different medical tests per patient, and then we see just a small picture instead of looking on the bigger picture. and that can be because sometimes people are typing in wrong data inside the EMR systems, the electronic medical record systems. Therefore, what we have done is to collect all the data, and the first thing that we are doing using the well-known standards, let's say, based on the WHO or the CDC, we are taking this data, we are reviewing this data, of course, by our algorithms, and we are providing this detection part. In this part, we also use, as I mentioned before then, imaging techniques, and for example, to detect pneumonia, to detect breast cancer on mammograms, to detect COVID on CT scans, etc. But the advantage here is that we are able to connect different data types to complete the whole picture. So this is the first step. The second step, as I mentioned before then, we are providing the predictions of pre-existing conditions. And how we have done this? So we have built SPY based on data that we have collected worldwide on over 300,000 patients. Very diverse data, very diverse population, different data types. And right now we are one of the only companies around the world that are analyzing any data type. And using this data that we have collected, we recognized new patterns and new parameters that are shedding light on the potential of these patients to develop these conditions. So we are providing these predictions of pre-existing conditions. In the pregnancy, we have by the way, we have 6 different modules. In the module that we are providing predictions around OBGYN, we are starting at the preconception phase. And I would like to share with you a quick story about it. When my professor approached me with her personal story, she told me, so I'm suffering from these abortions, and I'm suffering from these miscarriages and preterm births, and all of the physicians have told me we don't see any issue. So it seems like that is something that we don't see, that we are missing here. And when we started to collect the data, we assumed that there is nothing that can happen out of the blue, meaning if something happens inside a pregnancy, that means that in high probability, let's say, we can predict some of these, not all of them, of course, but some of these conditions before the pregnancy. And that's exactly what we've done. So in our predictions, we are starting at the preconception phase. Then we keep updating these predictions throughout the whole process of pregnancy, and of course the postpartum as well. The third part is the prediction of illness, of the progression of illness. And as I just mentioned, in order to show what are the changes in the course of pregnancy. So let's say that we started from one baseline, and now, even if we didn't, or if you didn't do any intervention, or even if the patient looks definitely normal in terms of the medical status, of course, so that doesn't mean that nothing has changed. And we want to make sure that this woman will complete her pregnancy in a normal way, let's say. That's the reason that we keep providing this progression of illness. So I would like to show you what does it mean. So here, as I just mentioned, we have different conditions that we are providing. On each of these conditions, we are providing whether the prediction is positive or negative, meaning if the patient will develop this disease or will not develop this disease. And here you can see that we have different types of conditions. Also, as I mentioned, we are providing the severity of illness. And why it's so important to predict what is the severity of illness in order to show or to reflect what is the severity of this specific disease, and also to enable the physicians, the medical staff, to see what is the impact of their interventions. But the immediate impact of these interventions, because we don't want to waste precious time here. If something is not working, so then you can see it immediately. Also, we are providing what are the features that we have found to be important using our algorithms. And the other thing that we are providing is the diagnosis part. In the diagnosis part, as I mentioned before, then we are reviewing all the data that is in the system, and we are diagnosing the current status of the patient. So our main goal always will be that the prediction date will be before the actual result date, which is the diagnosis date, of course. Moving forward from the maternal part to the neonatal part, we have connected between the maternal and the neonatal medical status, and that was very important to do because inside the pregnancy, there are two different things that we see, and it was very important to predict from the perinatal time until the postpartum to see what are the expected disease after just after the pregnancy with the delivery, meaning. So in this gap between the moment that the woman is delivering the baby to the moment that this baby is reaching the neonatology or the NICU, it was very important to fill this gap and to provide the neonatologists not only the all information about the course of pregnancy, but also the information about this baby and what to expect to, so they will be able to start and treating this baby, especially in the NICU, in the very first day. And that's all what the AI enables us to do by predicting all these diseases. So in addition to that, it was very important, and now of course we can see it in the very significantly in the COVID times, that is important to keep tracking and monitoring these patients even remotely. So I would like to share with you here what we have done with this. And our idea was to take the baseline as the all data that we have inside the hospital, and then to connect it to other devices or other questionnaires that we can actually do remotely, and to keep tracking this patient to make sure that this patient is going and improving, or nothing that is abnormal is happening during the course of pregnancy. So that's exactly what you can see here. We are starting here from the data that we have within the electronic medical record, and using the connection that we have done to other wellness watch, we keep tracking this patient. By the way, it helps us to see what is the behavior of the patient. Because, for example, let's say that we have one patient that at the preconception phase we found to have high likelihood to develop gestational diabetes. One of the interventions may be, the changes in the lifestyle. But now we want to see what is the changes and what is the commitment of this patient to these changes in the lifestyle. So we can use this data that we are collecting from other third-party companies in order to feed in our algorithm and keep doing these live recommendations on these patients, and then to help the physicians to make a more precise decision on the next steps or on the next interventions. And then you can see here that this patient is now pregnant, and then these are the predictions. Okay, so she is now in 9 weeks plus 5 days. This is the current situation, and this is the prediction. Also, we enable these patients to connect the physicians remotely, or to go back to their own physicians and have a frontal appointment. So again, all these connections are very important in the balance or in the combination between the detection capabilities that the AI is bringing us and the prediction capabilities, and this combination puts us in a place that we can provide the physicians a very strong tool that, based on this tool, they can do not only more precise decisions and more accurate decisions, but also to see these patients' progression and to manage care better. And in the last point, we wanted to take the precision medicine and make it a reality. And it was very important to see how we can use all this information that we are providing, which we start with the diagnosis, and then we continue with the predictions of pre-existing condition, and then we are predicting also what will be the progression of illness, and then we are helping to tracking and monitor these patients. And the fifth part is to help the physicians to make a more precise decision on what will be the most impactful treatment or intervention for a specific patient. So I would like to show you 2 examples of it. The one, as I mentioned, we are creating this patient profile, we are taking different treatments, and then we are recommending or showing what will be the severity of illness under these treatments. We have done this very successfully, even out of the maternal or pregnancy space. And in the COVID, we took different treatments that were possible. One treatment was dexamethasone. The second treatment was remdesivir. The third treatment was plasma, and etc., etc. And we use these predictions to combine between them and see what will be the outcome, what will be the severity of illness under each of these predictions. And you can see it also inside the pregnancy. So this is the detection part, and as I mentioned, and this is the live recommendations, where in the black line you see what will be the prediction of glucose levels without any intervention, and what will be the prediction of these glucose levels under each of these interventions. So it's kind of a sophisticated simulator that will leverage, if I was talking about the powerful tool of recommendation systems and reinforcement learning, which is the last section that I touched when I explained about AI. So here you can see why it's so powerful, because it enables us to see what will be the outcome even under different interventions along the way. So if you think about it, it's kind of Google Maps or the Waze that even before we are starting the driving, we can see what to expect to in our way. So it will give us the estimation, so we can estimate when we need to leave our homes and when we are going to reach the place. The other thing that it is doing, it is keep predicting and updating the estimation time. But not only, it is flagging us on some challenges that we may have along the way. So this is exactly it. And the third thing that we are reaching here is that it will recommend us on changes in the way if it sees that this way that we are on now is not the shortest way, or it's not the best way to reach the place, but we have a better way to take. This is exactly it. The last thing that I wanted to show you is actually the top of this combination between these different techniques that I've just touched, which is taking the detection part and taking the prediction part and taking also the what we called the IoT or Internet of Things, or how we connect the radiology tools to be more precise, to be automated, and to leverage this technology in order to recognize these defects before something is happened. So what you can see here, and we present as the SPIDey, the next generation of radiology tools, we have used an add-on on the ultrasound or the regular ultrasound transducer. We connected all the data from the EMR through the ultrasound system to not only detect, but to use this EMR data to predict on the image what is the abnormality that we see, or if it's LP, of course, as well. And then we teach this brain, this machine, how the physicians, or what is the position of the physician's hand during the examination, the ultrasound examination. That enables us to build a robot that is mimics all the process from the moment that we define what is the purpose of the examination until we are doing or performing all the course of examination by the robot that just mimic the physician's hand. And then it is doing also the aggregation of data, and it is doing also the prediction on the image. But think about it. Now, if we have such diversity or such differences, and I had the honor to be in the ultrasound unit for Siemens Healthineers, and such differences between one system to another and between one physician to another, think about how we can minimize this process to the moment that the physician just need to make the decision. So we are leveraging this tool in order to provide the physicians the power to make a more precise and more accurate decisions. So I would like to complete my talk with Fei Li. She's very unique in this space and she's with Sequoia Capital and a professor of computer science at Stanford University. And she says the day healthcare can fully embrace AI is the day we have a revolution in terms of cutting costs and improving care. So thank you so much for your time, and I hope that you find it interesting. I would love to address your questions later on. So thank you so much.
Thank you.
Sure. So I believe that now Dr. Haberman should join us in a few moments, or I see that she's here. So I will share my screen. Let me.
Hi. Good afternoon. Here it's my morning. So yeah.
Oh, great.
I'm in New York. Yeah.
Okay, so let me just share my screen with your presentation.
I let Hila get the slides because it made it easier. So Hila will bring up my slides. In the meanwhile, just brief introduction. I'm the director of maternal fetal medicine at Maimonides Medical Center. We are the largest obstetrical service in New York State and one of the large in the country. And besides being the director of maternal fetal medicine, I'm also the director of medical informatics for OBGYN and member of the hospital task force in medical informatics. Doing it for so many years, I got deep interest in artificial intelligence and machine learning system, asking myself, how can we improve our processes, which as everybody which practice medicine these days knows that we have many issues with analyzing data, quality of data, overwhelming amount of data element which we are being bombarded with, and it's very difficult to pick up out from all of those data elements, the ones which are really important for us, and lot of processes and the protocols that we are using basically based on data when you start to dig into was not analyzed in the most accurate and obviously not that precise for the individual patient. So I started to work with Hila to say I don't have any conflict of interest, I don't have any shares, anything in the company. I'm just working with Hila as a clinician and the person which needs accurate, precise data to manage my patients. So the place of artificial intelligence, as far as I'm concerned, and the way that we can use it is summarized in this slide, creating more precise analytics for images, pathology or radiology images. And I would citate Jeffrey Golden, that we are now getting to the point where we can do a better job of assessing whether a cancer is going to progress rapidly or slowly, and how that might change how patients will be treated based on the algorithm rather than clinical staging or the histopathological grade. And if we can, I assume that most of the audience are in the neonatal field. Let's assume that we do now imaging of the fetal brain. We find certain things, and when we deliver the baby and you get the neonate, it's very difficult to predict the neurological outcome, the development outcome, based on just the imaging. As everybody knows, we see certain things in our fetal ultrasound that immediately after delivery you might not see, but things might shown later on in life. And I think that right now it's an enigma how to follow, how to manage, and how to consult these patients. So that's one of the areas which can be improved a lot by using AI and machine learning. We can improve productivity by identifying features of interest in the medical data before human clinicians review the data. Because if instead of looking at 40 pages of record that someone brings to me on patient with some adverse obstetrical outcome, I can get precise information, focused and highlighting the most essential elements in the situation. Obviously, I'm saving time and I can be more productive in how I'm counseling the patient. And also, if I have a population, if I'm dealing with population and I'm trying to solve some problem which being identified in this population, obviously more accurate information can help us to solve those problems. And this is real. We are seeing it using those type of systems. Now, bringing intelligence to medical devices and machines, obviously pattern recognition, and some of our challenging is how to analyze fetal heart rate. Still, the precise information is not there. There is a lot of information into this fetal heart rate monitors, but we are missing certain points that only machine can address for us. Our eyes are, especially trends, which it's almost impossible to do trend analysis, and obviously radiology data. Now, bringing intelligent to assess our ability to identify early sign of deterioration is one of the most important things for me, because we see, as Hila mentioned in her lecture, you can see 3 patients which present to you almost with the same picture, but one of them will develop a condition and the other 2 will not. The capability to identify the one which I need to target for more testing or for earlier intervention is very important. And all of us know about those patients which look completely normal and all of a sudden deteriorated. And as Hila said, this is continuum. The system enables you to detect patients from preconception toward pregnancy and during labor and even postpartum. And I don't need to tell you as neonatologist how many conditions present later on, but when you really look backward, you find already the early signs of they're there. Enhancing the clinical decision-making with artificial intelligence at bedside, it's really important for me, because that's, again, we are missing a lot of things, and systems like that can pick up the essential from the data and can help us to provide more precise information, identifying and highlighting elements that are important to manage the patient. Also, as Hila mentioned, we know that different physicians are managing situation in a different way. That's part of the thing that can be entered into algorithm, because at certain point, you can provide different alert to different providers based on their behavior and their part and their way of managing patient. Next one, Hila, please, next. Okay, so the artificial intelligence can help with analyzing imaging, better digital signal processes in fetal heart rate, EKG, for example, and also highlight and analyze EMR data much better, and also combine a lot of, we are bombarded with information which come from many EMR or many sources of data, and only system like that can combine all the elements together, put them, and also it's very important to clean the data as far as hierarchy, because you might find some lab which come from a certain entry to a record, and from the other end you have lab results we stream directly from the lab. So those systems can clean those data elements by hierarchy and kick out the ones which the system, by artificial intelligence machine learning process, knows that those data elements are not coming from reliable sources. And obviously gather all the signal together. Hila, next one. So we looked at prediction of we looked at several adverse pregnancy outcome prediction models, and we built those prediction models based on a huge number of patients we had in our database in order to get the training part, about 100,000 deliveries, and Hila had also in her database several 100,000 from other resources, and the mathematical model was built based on an analysis of many patients. So we are aware that the genetic data is very important. However, most of the systems do not include that data, and even in our sophisticated systems, the genetic data comes in a format that not always we can analyze it accurately. We are making now some efforts to get into the core of this genetic data that we have on our patients, but we decided to take a surrogate, some demographic parameters that usually are not included in detailed analysis. We looked at language, religion, besides race and ethnicity, we added the religion and the language, and we found that there were significant differences in the probability to develop gestational diabetes based on just religion. And one of the things which was interesting, that in our population, the Jehovah's Witnesses were at the highest risk to develop it, even more than by tradition. We saw that the Orthodox Jewish community, which is usually Eastern Europe community, were at much higher risk. Hila, next slide. So that's one of the things that, Hila, next please, that can highlight it. So when we worked on the model, it was clear that we have to develop different prediction model based on religion. So for that example, the performance of that model on Jewish patients, we got specificity of 99.3 and sensitivity of 65, and on just the Christian model, on the Christian model, we got 98 specificity and 88 sensitivity. So it shows how different even religions factor can have different impact on your prediction model. Hila, the next one. Now, that's another example of something that we overlook, and these parameters never came to all the analysis of prediction of gestational diabetes or risk development of gestational diabetes. The system, the prediction model brought up that besides the number of pregnancies and the number of prior pregnancies affected by diabetes, one of the most important factors is if the gestational diabetes was on the last pregnancy or was earlier. And you can see on that model, you can see here on that results that, for example, patient with 4, Hila, can you highlight it? 4 pregnancies, and 2 patients, one had 4 pregnancies and 2 prior gestational diabetes, and the other one had 4 pregnancies and 2 previous gestational diabetes, but one of them had the last pregnancy with gestational diabetes, and you could see that the probability changed from 20 to 45% just by putting the order of the gestational diabetes in those pregnancies. And this can be done in the preconception time. We did these predictions in preconception, on preconception data. Next one, Hila. Hila, next one. So, and other things which came up with our prediction model were a lot of blood tests and other factors, which some of them are clear to us, like age, body mass index, but some of them were not really intuitive. Hila, next one. And as well as different lab tests, which, as you see, change the probability for the development of gestational diabetes. And one of the interesting things was toxoplasma infection. Cholesterol, again, we know that people with hyperlipidemia might develop it, but things like toxoplasma or nucleated red blood cells came as factors. And if you really think, next slide, if you really think about what it is, the body is the whole body, and each disease has impact on other factors in the body, and also is being triggered by all systems. The hormonal system affected, the immunological system, the respiratory system, the cardiovascular system. Every system in the body contributes to the outcome. So this kind of artificial intelligence-based methods can pull out those special elements from each person, bring them up, and make the difference between 2 patients which on the surface look exactly the same, but even with certain little differences, basically have a big difference in the outcome of certain disease. That's basically some picture that I took from one of the books showing how all systems are connected, but I guess that you understand the whole idea that we are picking up elements from every system, which naturally and by our regular knowledge, we might not even think to pick those elements. Can you bring the next slide? So the artificial intelligence system has the capability, based on analysis of large data, to learn the situation and provide us with different elements which are important to make the diagnosis and predict outcome. And by this way can help us to influence and affect the outcome by early intervention. In gestational diabetes, it's obviously simple. If we predict pre-gestational diabetes, there are a lot of ways that we can intervene even before the patient gets pregnant. And Hila showed basically these busy slides before. So let's go back, Hila, to the previous slide. Hila, can you go to the previous slide? Yeah. So prediction from preconception phase to prenatal and postpartum can be done more efficiently by using systems like that. And it has significant importance because early intervention can change the outcome. And in diabetes, as we said, obviously there are dietary intervention, physical activity, combined diet and physical activity, and sometimes pharmaceutical intervention, and there are other interventions that can be done. And I would like to go, please, to the previous slide. So I would like to emphasize that it's not only one point at the course of the patient encounter with us or with some other people. If we see the patient as preconception, we can track down the intervention. As Hila showed you, we have a way to track down what intervention helps. So sometimes we see the patient early in pregnancy. We know from our experience that certain medication work on certain people, certain medications do not work on certain people. And this system enables us to give more precise treatment to patients. Monitor and tracking during pregnancy is another back. Monitoring and tracking the high-risk patients during their pregnancy is also important, and those systems can guideline on how often we have to see the patients, and who are the patients which has more severe situation and with the patient which health situation will not deteriorate. And that's important for monitoring patients. Then the system can also predict outcomes during labor and postpartum. And I have to say, we put the example of gestational diabetes because we did a lot on that and we published already, but we are working on other outcomes. And I had just a striking case that we just starting to put the preeclampsia prediction outcome. We had a patient that presented at 39 weeks with borderline elevated hypertension, was delivered, diagnosed as hypertension. She had also gestational diabetes in the background. She was delivered as gestational hypertension, 3 days in the hospital, stable, was discharged with no events, sequelae, any things that on our radar were highlighted. The patient, this is the right part of the screen. This patient was discharged, and 10 days after that, she was admitted with hemorrhagic stroke to another hospital, was transferred to us. And unfortunately, at that time, we didn't use that as active, the preeclampsia prediction. I looked backward, and it happened that she had two medical record numbers. So it's not like looking backward to what the system predicted. On the day of the discharge, that's what the system predicted, stroke by 73.55. And then the patient had slow recovery, and she's in a rehabilitation place right now, doing better. And when we took further history on her after she could communicate, it happened that she was told to measure blood pressure at home, but she was not that compliant with that. Few days after the delivery, she measured the blood pressure. It was 140/90. She saw that she was in pain and upset, and she ignored it. Then she started to have some headache. Only the next day, she had severe headache, collapsed at home, and was brought to the hospital. Obviously, this patient, if we would have this prediction upon discharge, which theoretically we had it, but at that time we still didn't use those predictions on the preeclampsia model, we could probably prevent that outcome, because this patient would be monitored very carefully. Her blood pressure would be watched very carefully, and there would be intervention immediately when her blood pressure would go up. So that's one of the examples which system like that can do that. And the right side is another patient that came also with COVID and was completely stable, and then all of a sudden deteriorated. The system on the day of admission, before everything happened, predicted preterm delivery and sepsis and ventilation. She ended in the ICU ventilating. So there is there is prediction power over here. And Hila, can you move to the previous slide? So there is prediction power, and basically using those systems, I'm completely convinced that the way to proceed with medicine these days is to develop those systems, learn how to use them, validate them, which is part of the process, and understanding that while this artificial intelligence will not come at once, early adopters in their practices will be ready to be future leaders in healthcare. Because I think that in the current status of data and overwhelming data and more information that needed to us in order to manage patients, there is no other way to deal with healthcare systems rather than work on those systems, develop them, and adopt them. Thank you.
Thank you very much, Oshana. Moving to the next, right?
Thank you. We will move on to the next topic. Wonderful presentation. A lot of questions. We'll take up the discussion of this third topic. I request Kishore Kumar, sir. Yes?
We are able to hear you, actually.
Can you hear me?
I have to say, I have to detach from you because I'm covering service and I'm already 8 minutes late. So I have to run to the hospital. So I think that Hila is capable to answer most of the questions. And if you have anything special, you can email me. I can send you my email, and Hila can provide you with my email as well. So have a nice day, the rest of your day, and bye.
Thank you so much.
Thank you very much, Friedmann.
Thank you, Sushana. And Dr. Prashant, will you be introducing Dr. Kishore for the next talk?
Yeah. So Dr. Kishore Kumar sir, he is the Vice President of NNF National Neonatal Forum Karnataka State Chapter. He is the founder director of Cloud9 Group of Hospital. He is the Harvard executive holder in healthcare management, and he's a pioneer in India to start a concept of mother and child, which has revolutionized the concept, mother and child healthcare system in India. And he's been the pioneer in setting up this trend in India, and he has got many awards and many. It takes a lot of time to go in detail of every achievement what he has done. So I request now Kishore Kumar sir to start the session and give a brief introduction about the concept. Over to you, sir.
Good evening, Prashant, and good evening, Ganesh Prasad. Thank you very much for that kind introduction. Before I start, I want to congratulate both Hila and Dr. Shoshana for the wonderful presentation and the great work they have done in artificial intelligence. For those of you who may not realize, artificial intelligence takes a lot of time. In fact, we had been working on the similar sort of things for quite a number of months and a couple of years, and still nowhere this close. The good thing about neonatology is a very youngest branch of medicine, and as you can see, it's less than 60 years old, and clearly that makes one of the young medicines with the evidence-based medicine. So it is a area where artificial intelligence can make a huge difference. And you can see the major milestones which has happened in the neonatology is most of them are in the last century. 21st century is yet to come up with any major milestones, and I'm sure artificial intelligence is going to make a huge difference. If you look at artificial intelligence in neonatology, when you do a Google search, and there were 7,260 in the Google search, whereas in PubMed there are only 62 articles on artificial intelligence in neonatology. Harvard Business Review talks about artificial intelligence and machine learning in various things, but neonatology is mentioned passing by. So neonatology is not in the major area of many people. And if you look at the latest data available from Government of India, we have still one of the highest mortality in India. And if you look at Karnataka, it is one of the better places to deliver a newborn compared to the worst states, which are Chhattisgarh, Bihar, Assam, Jharkhand, and Rajasthan. So the progress with the neonatal mortality rate has been very slow but steady, but it's painfully slow in India, and with the southern India doing better than the middle part of India compared to the rest of India. So the funds available, there is enough funds available, but it needs to be used in the right sense. Now, why is artificial intelligence matters to India in a big way, especially in neonatology, is because India accounts for almost 27 million births, out of which 13 million babies are born preterm. And preterm babies, we all know that high risk of death due to neonatal infections, high risk of developmental delays, high risk due to cerebral palsy, poor school performance, and increased chronic disease in adulthood like cardiovascular disease. And we all know that not all preterm babies are the same. If we can have artificial intelligence to identify the risk factors for the late preterm and extreme preterm, we will save a lot of babies from mortality and morbidity in a big way. Artificial intelligence neonatology is quite challenging, people think, but it's actually, if you break it down, as Hila showed in maternity, They have done such a wonderful job. It's all about algorithms. And in artificial intelligence, if you can draw an algorithm and you have an analysis, you can perfect it with the data. There can be no better country than India with the 27 million babies born here for creating algorithms and a database, because data collection is the most important to test the artificial intelligence. As you can see in this cartoon, the predictive analytics and other things are all given with the data, and I think Hila explained how it works with algorithms to identify the risk factors and gives the output. If we can identify any baby born for any mother who, for example, has high blood pressure, gestational diabetes, the risk of this baby developing RDS, PDA, NEC is this, then you can actually predict those things and prepare rather than treating once the problems appear. And if algorithms can identify which babies are at risk for these, for example, if a baby is born at 34, 35 weeks, you're not sure whether to admit to the NICU or not. And if we know the risk factors for respiratory distress for this baby, jaundice and temperature instability, then we can use that either for discharge or admission to the NICU in various ways. Readmissions and various other things are showing that there is an increased cost. So this can actually cut down the cost. Secondly, I showed the data of the various states. So with the various states having such a huge discrepancy in mortality, morbidity data, we can actually use that as a hub and spoke model for referring the babies to the higher center before it's too late to reduce the morbidity and mortality. So if algorithms can identify the risk of babies for hypothermia, hypoglycemia, hypocalcemia, hypothyroidism, HIE, then definitely we can make a huge difference to the neonatal mortality in a big way. So any baby who is born between 34 and 36 weeks, we know that it is a late preterm baby. But the more preterm the baby is, the higher the risk of respiratory distress and sepsis and apnea, we all know. But which baby do you admit if the baby is more than 2 kilos? Which baby do you send them to a neonatal unit? Or which baby do you discharge early? So this is where artificial intelligence can help us if we have algorithms identify the risk factors and give us, these are the babies which you need to watch out. These are the babies you can safely discharge. And for that, we need a lot of data, and definitely we can do that. If we do that, the cost of treatment of a premature baby can drastically come down, and there can be a lot of the savings, this is just a projection of the cost saving which can have in identifying the problems. So in other words, the goals and objectives of artificial intelligence in neonatology is early identification and intervention and reduction of the childhood disability. So artificial intelligence algorithms involves a lot of data input from various professionals and algorithms analyzing those data and going from there. I'm running a bit fast so that we can have time more for discussions. If you want to interrupt me at any stage, please do so. So similarly, we don't screen the babies for complex cyanotic congenital heart disease throughout the country. But if artificial intelligence can identify at-risk babies, we can definitely reduce the number of babies who needed to undergo the test, reduce the cost, and reduce the morbidity and mortality associated with that. I don't need to emphasize on congenital hypothyroidism because we know that this is high incidence in India. But if artificial intelligence can give us the prediction by either doing a cord blood or anything at sooner than later, even early discharge probe babies can be identified much earlier. India has one of the highest incidences of congenital adrenal hyperplasia, and we all know that our traffic lights are always occupied by hijras and other people. And the reason because it's a delayed diagnosis and no treatment and these can be avoided if we can predict the babies with the artificial intelligence. Extreme prematurity, attending any delivery is an emergency, we all know, but especially so of the extreme preterm babies. If we can identify which lady is going to go to extreme premature delivery, then we can do the hub and spoke model and refer that lady to regional center in utero to prevent the problems from causing. So artificial intelligence in newborn or neonatology can help us intervene and do things by having the team ready for ABCDE much earlier than later. And especially in an extremely premature baby, we all know that hypothermia, hypoxia, hypercapnia, and hypotension are very, very common, which accounts for almost 70% of the morbidity and mortality, which can be decreased by appropriate algorithms identifying these babies for risking. We all know that India has a highest retinopathy of prematurity because of various reasons, which beyond our discussion today. But if we can identify the risk babies and we can reduce the amount of time involved in the ophthalmologist doing the screening on all babies rather than just doing the high risk babies, and make sure that we don't miss any ROP. Similarly, deafness, if you identify the babies at risk, a lot of the rural areas will benefit by getting screened only the at risk babies so that we don't provide definite babies. So artificial intelligence has great expectations, and we have a lot of data available. We have a lot of births available in India. We have to work through the artificial intelligence and algorithms to get there, and it is not a quick process, as Dr. Shoshana explained, and certainly we can reverse the Kubler-Ross change curve by creating integration of the data into decision making, and we can experiment that, and we can definitely improve the neonatal care. So neonatal care to move into the next century and India to become a developed country, we have to invest and we have to focus on artificial intelligence. That is my few minutes of wisdom, and I was asked to do this lecture only a few days ago, so I prepared this with the stimulating thoughts so that the younger minds can definitely take up this project and work on it, and we can guide anybody who is interested to go through this. And certainly we have a raw material, we have the intention, we have the funds, we just need to work on it so that we are the leaders in the area. Back to you, Prashant.
Thank you, sir. Thank you for that thought-provoking presentation. So before we start the discussion, we have three panelists today, Dr. Prakash Mehta, Dr. Megha, and Dr. Leena. So I request them to share their views about today's presentation. We'll start with Dr. Prakash Mehta, sir. He's the president of Fetal Medicine Association of State. Prakash, sir, over to you, sir.
Yes, I think it's a very, very interesting concept, point number one. Point number two, as it has been repeatedly pointed out by all the speakers, that data is very, very important. Point number three, I think economics, if you see in the general population overall, could be a little bit of a problem. But if you, as far as high-risk pregnancies go, I think that should not be an issue at all, because any woman who has had a previous pre-eclampsia complication or a previous preterm labor, I don't think she's going to look at that kind of a cost. I can give you some very simple examples. Just a few days back, I had a lady coming into the hospital for delivery at 30 weeks, unbooked. She was booked in one of the government hospitals, and then she came over suddenly to us. And I was really worried as to how things would go, because the baby needed ventilation and everything else. But she did pay up. So what I'm saying is that we just cannot look only at the financial aspect. Because given a choice, a patient will somehow do the things. The more important point I would think is the data building, because a computer tells you what you have taught it. If you don't teach it properly, or if you have a bias while making the program, it is definitely going to make an effect. Number three, the amount of epigenetic influence in India is something that is phenomenal, whether you take preeclampsia, whether you take preterm labor, or whether you take postpartum hemorrhage. So I think a lot of hard work is required. I would say if we all determined to work, maybe in the next decade or so, we should be having a strong database based on which we could build up this kind of artificial intelligence system. Whether we like it or not, that is the future. And for anybody worried, artificial intelligence is never going to replace experience. It can never replace experience. What it'll do is to help us to treat our patient in a better way, more precision, more cost saving, less complications and less litigations. That is what is going to happen. That would be my take on this.
Thank you, Prakash sir. Kishore sir, would you like to say something? Kindly unmute, sir.
Yeah, Hila, at the outset, I want to congratulate you for the wonderful presentation and the wonderful work you have done on Gynisus. I wanted to ask you, how long have you been working on this maternal artificial intelligence algorithms?
5 years.
5 years, wow. And now
it's
you have
not a work that can be done in one day, but you know, to accumulate and as just Professor Mehta just said, it is very important to be very precise while building and while using this data. So that's the reason that it takes that long, you know, because sometimes we have other restrictions also in this space that, you know, building by old methodologies and all that things. And when we are trying to use AI as something that will shed light on new parameters and new other things that are important that we weren't aware of in the past, then it takes very long time, you know, to open it first and then to validate these things. And that's the reason that that we worked on it that long.
No, I do understand. I think the reason I asked this question is the audience should know that artificial intelligence doesn't happen overnight, and it is a long process. And once you have created the algorithms, getting the accuracy with the algorithms is so important. I'm very impressed with your algorithms giving the prediction of gestational diabetes, hypertension. And last time when we spoke, you mentioned about reduction of C-sections. Maybe you can highlight that point here, Hila, because I think India in the private sector has got one of the highest C-sections. Though nobody admits it, the C-sections in India in private sector is almost 60 to 70%. So maybe your artificial intelligence can help that to bring down significantly. Again, I am talking on a non-confirmed source on the private sector, but just maybe throw your light on how your artificial intelligence reduce the C-sections in your trials.
Yeah, sure. And I don't know if Dr. Paidas from the University of Miami has joined us here, but if so, I want to congratulate you and thank you for joining us, Dr. Paidas. And the reason that I mentioned Dr. Paidas is that the same numbers are being seen in Miami population, where we see, you know, 40% of cesarean sections, which is the highest rates in the US actually. And regarding your question, Dr. Kishore, since we are predicting, you know, whether we will have any of these complications during the L&D, as Dr. Haberman mentioned before then, it is helping us to see whether these patients need to have the cesarean section or not. And also, you know, other complications in L&D, for example, is shoulder dystocia. So if we know that this patient is not going to have any of these complications, then we can make more precise decision on the mode of delivery, right? I'm not to mention, you know, breech presentation and other things like that. But in general, if we see that, or if we predict that there will no any complications, then it is helping us to make the decision to go with the vaginal delivery.
I just have a question. Do you add multi-omics or proteomics, genomics when you make your artificial intelligence algorithms? Have you been adding that?
Yes, of course. So as Dr. Haberman mentioned, there were challenges. Genetic data is it's something that, of course, we all know, but it's not something that has been used in the past years in daily, let's say in daily or very frequent examinations. So it was pretty rare. So what we've done in the places that we did have this genetic data, we combined in a very unique way, and she showed it in this table that is shedding light, on the religions, races, ethnicities, etc. And we've done this combination between the different demographics data that we have to different biological signs that we see, as well as genetic data. So then it puts us in a position where we are able to complete these missing elements, sometimes, in genetic data, and get over it using, different parameters that we see in common for a specific population.
Yeah, just one more question to add on to that. Have you used any electrohistography to identify in-coordinate uterine action using artificial intelligence?
You're talking about elastography, right?
Yeah, the labor procedures.
That's very interesting. Unfortunately, elastography pretty, I don't know how to say, disappeared from this space of ultrasound and other spaces. And for those who are not familiar with what is elastography, it is just a way to examine the mechanism, or not the mechanism, but the mechanics, the mechanics of the organ, to see whether it's stiff or etc., and to have a better estimation using this tool. So this is just closing this parenthesis. And regarding your question, so I've worked personally a lot around this space of elastography, and what I've shown before then, maybe I can reshare it again, just for the purpose of answering this question. So if you see it here, okay, so one of the things that we were able to do here is to put some sensors on this smart add-on, what we call smart add-on, and collect the parameters of the tissue, and to see what is the different characteristics of this tissue. It was very important because the studies that have done so far with this elastography was around just pressure, applying the pressure on the tissue. The issue with that was that it was inaccurate, and it was inaccurate because you are applying pressure on the fundus of the woman, but you don't know what is the pressure that you are applying. And we all know about the Newton laws, that if you're applying pressure on something, it will resist in the same pressure. And if you don't know what is the pressure, and you don't know what is the area that you're pushing, then it's inaccurate. So that's exactly what we have done to make it more accurate. We are, as you can see here, the signals, we are measuring what is the pressure that is being applied on the fundus, and then we are measuring here the same pressure what we get from the other side through the transducer. And by doing so, we are connecting the picture to see what is the real elastography picture, with a lot of other parameters, by the way. So it was pretty long answer. So
now, just last question. Now, when you do the data mining, how do we protect the patient rights? Because the data mining becomes very important.
Definitely. And as I mentioned before, then, as someone that came from the cybersecurity space, and I've started my career in the cyber security, it is something that we put in on our top of our priorities. And we have very clear and I would say strict process to clean out the patient data. And what we are doing, the first thing, we are cutting off all the data and we keep the data, the personal data, or what we call the PHI data under the HIPAA laws and the GDPR laws in the hospitals. And this is very, very strict in our company, and we are working closely with the Microsoft team around all these things of integrations, making sure that all the integration is very secured, and cut all the data, the PHI data, and keep it in the hospital.
I asked that because our ethics committee is so strong that they will not allow us to touch so many things.
Sometimes we are even more strict than the hospitals, I have to say that, but yeah, definitely.
And one final thing that we may face in India is, say, like when you need an ultrasound picture to build up the base, you need to share the ultrasound picture. It could be just for NT, or it could be for FGR to see the femur size or whatever. But in India, we have the PNDT Act. And under the PNDT Act, we are not allowed to share the pictures. So I don't know how we are going to overcome this when we try to bring, build a data on it, because without an ultrasound examination, none of the data are going to be complete.
See, there are first you can take the outcomes of the ultrasound examination, right? Let's say the bottom line or the diagnosis out of it. So it's not that barrier. Having said that, there are ways to de-identify also the images. There are simple ways, well-known ways to do it. So it's just to present to the IT people the way that to de-identifying the data. And it is a bit more challenging to do it on data that is coming from tables. That is true, but it's doable, definitely doable, and we are doing so everywhere in the world. I mean, in Europe, we are subject.
No, I think we are the only country in the world which has got a PNDT Act. We are the only country.
But, it's everywhere, because in Europe we are subject to GDPR. In the US we are subject to HIPAA laws. So everyone has these restrictions.
Dr. Mehta, you are not sharing the data with anybody. You are analyzing your own data with the artificial intelligence algorithm. So right. PNDT doesn't come into picture.
But when we build the algorithm, we need the complete database.
Correct.
Because before building the algorithm,
you're not sharing the data with anybody.
In Indian babies, this is the femur length at this particular stage, or this is the NT, how it has to go. This is the cut which the machine is going to pick up. So the machine needs at least 3,000, 5,000 pictures before it builds up that algorithm. So I'm talking about that stage.
What I'm saying is you're not sharing the data with anybody. You're sharing the data with the computer which does the algorithm and calculations. So I don't think PNDT Act will come into that.
The because picture has to be given. Picture.
PNDT has to be given with the sex of the baby.
Exactly.
The picture of baby has to be shared, because let us say, for example, you take femur length. If I'm doing biometry and I'm depending on an artificial intelligence to give me the fetal biometric value, then I have to share the femur picture with the initially, at least till the database is built.
After having said that, the advantage that we have on images is that, images has no difference between one population to another. So you have the same, you will see, for example, abnormalities within FHR. They will look the same in the US, or the same in Israel, or the same in Europe. And then if we are using the same algorithm to analyze these images or signals, on that part, it will be totally fine. And the part that will make the difference will be the other data, the entire data, the lab test, the genetic test, and etc. So on that part, we are on the safe side. Yeah.
Thank you.
Sir, sorry to interrupt, Balaji here. Sir, just to answer your question, we don't need the images also, sir. We can only take the report, ultrasound report, which has a femur length and BPD and all the measurements, and that can be incorporated in the software. So ultrasound images are not mandatory.
Yeah, okay, I think that makes it much better.
Yeah, if image is not needed, then how to, we need to have some certification, some authentication for, unless we see the image, we'll not be able to rely on it.
So it
That's
was
a little bit of a catch-22 situation particular to our country. I don't know. I think over the next few years, we may be able to get around to it. God only knows. But I think as far as preeclampsia, diabetes, preterm labor, parturition, we should be able to do quite well with an artificial intelligence, at least the next 1 decade or so, if not longer.
And as I mentioned before, then we already trained these algorithms on a massive population for, for the imaging. So that is something that will not need to retrain on different population. This is what is unique with imaging, right? So this is just an advantage here that we'll just need to provide the algorithm as is, so no need to extract any data or image data outside.
True.
Yeah. If you have any questions, audience, they can raise their hands. Dr. Megha, yes, you have raised your hand.
Yeah, it's a very good idea and innovative too, and that is definitely going to improve our evidence-based practice, especially as Dr. Mehta has said about preeclampsia, preterm labor, and gestational diabetes. It's going to help us a lot in that situation. And one more thing, as a private practitioner, I would say that this is going to help us to counsel the patient and the family about the grievancy of the situation and the complications she is likely to have with the algorithm, and that is really going to help us in private practice also. Thank you, Hila Friedmann. It was a very informative lecture, and I'm really thankful to you all. Thank you very much.
Thank you very much.
Thank you, Dr. Megha. Audience, do you have any question? You can directly unmute and ask our panelist and our speaker. Dr. Leena, I just had a break in my internet. Dr. Leena, are you there? Yeah. Ganesh ji, would you like to add something before we close the session?
Prashant?
Yes, sir. Yes, sir.
It's a very wonderful talk. Kishore sir, very nice. Both the speakers are very good. I don't think there will be much problem about even ultrasound biophysical profile. This thing, because we are not showing anywhere the sex determination here. And one more thing, we are not even revealing anything other than what we need, the chest biophysical profile, whatever the 5-6 components are there. So we are not going to, we are adding that, and even cervical length and other things we are adding. So it is very good actually, artificial intelligence. Number one in the predicting the delivery. So more than, and in the neonatology, there are 2 more things what I have seen in my eyes. It is already there, like ICON, 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 OCPAC company medicals. OCPAC, it is from US. Okay. So that machine just put 3 probes. One is near the neck, left neck, another is near the left apical region, another is just below the apical region. So that 3 probes will, and SpO2 and HB percentage, we have SpO2 we have to enter HB percentage, we have to enter. That's it. And HB percentage, SpO2 and NIBP. But everything is available. One more thing, Icon, Visaka, that is a higher end version. It will cost 27 lakhs. So only if you will bargain, it will come down the price. So with the Mesimo technology incorporated in that, just by seeing the SpO2, NIBP, and 3 patches, one patches near the left carotid, another one near the apical beat, another one near the femoral for the neonate, for the pediatric and adult, another one near the just below the left costochondric angle. If you will with only that patch, it will give the cardiac output, cardiac index. If you will enter the body surface area BSA, or if you will write the length and weight, it will only calculate. You are going to get what is systemic vascular resistance, all the parameters with the calculations it is giving. You need not worry about what is the cardiac output, what is afterload, preload, whether it is increased, decreased, everything it will only give. And more than that, even lung fluid capacity and what is the compliance, that itself, everything it is giving. That is one more new thing in the neonatology. It is there. I think so. It is one is there in the at present they are studying in India in St. John's Pediatric ICU. Another one is PGI. It's a very good machine. It is. And then another one is Hero Score. That is also with all the bio parameters. It will only tell whether baby will deteriorate in near. That is also artificial intelligence. It is very well in neonatology. That is also there. Hero Score 1, Icon 1. And one more thing is there in the neonatology, whether this baby will succumb immediately, whether it will be after the, because if the premature baby is delivered, whether because of the infection it is delivered or not. There is total fluid lung capacity and the not culture sensitivity and other things. There is one more algorithmic parameter with that. That is also there predicting whether this baby will die or not, like oxygen index and other things. These are the 3 things I have seen recently in the neonatology. And that is with artificial intelligence and calculations, everything is there. Without not even one is invasive. Everything is non-invasive. So over to Prashant.
Yeah, thank you, sir. Thank you. Thank you. I think we had a very good presentation.
Yes, sir, one more doubt.
Yeah,
are you working on any kind of an algorithm? Because I came across one of the articles recently that GDM, gestational diabetics, going on to develop diabetes in future. Are you working on it, or do you have any experience in it?
Yes, of course. We already have these predictions in place. We are working on new publications. A lot of publications are on the go with different collaborators. And I see that Dr. Rob Coppell just dropped out, maybe joined in again, but he's one of the neonatologists that are advising the company around, is with Northwell and are advising the company around everything around the neonatology. So we have now RDS prediction, we have sepsis, we have other complications like this. And the advantage here is that we are providing these predictions at the very first day, as I mentioned before then and showed our platform.
Thank you.
Thank you. Thank you. So we had a great discussion about the thing which is already there, which is giving a great prediction of high-risk pregnancy and prevention of complication. So it's always the obstetricians and neonatologists hand in hand, which can create a very bright and very healthy future of the nation. So, and with the artificial intelligence adding to that as a third eye for the neonatologist and obstetrician, definitely the future is going to be something very good and very promising. So, Hila and all our speakers, thank you very much for accepting our request to be part of this webinar session for this new type of webinar session. Otherwise, we would have more of a clinical based with pathology, pathogenesis. So this is something which, as I said, it's going to be a third eye for the doctors in terms of anticipation and preventing the risk and complications. Thank you for your wonderful presentation, Hila. Thank you, Dr. Haberman and Dr. Kishore Kumar, sir. So we have our National Neonatal Forum Chapter Karnataka President, Dr. Kotreshi over here. Sir, would you like to speak a few words and then we'll close the session? Kotreshi, sir?
Hello, Prashant.
Yes, sir.
Can you hear?
Yes, sir. Yes, sir. Please go ahead, sir.
Amongst all the web series, this is a wonderful series because a prematurity can be prevented or can be taken by the mother itself, and even the instrumental delivery all have been tackled very nicely. And amongst all the guest speaker, I appreciate the involvement of their subject also. So, on behalf of Karnataka NNF, I am very proud to say these type of series have been conducting so nicely, and it's the best serial amongst the preterm care has been taken care. And I am very much thankful for the speakers and participants also. Nice of Prashant.
Thank you, sir. So this webinar session wouldn't have been possible without the support of Mr. Ganesh and the GenWorks. We have made it possible, and this information is going to reach each and every one, and we'll be uploading this in our official NNF Karnataka chapter Facebook page and YouTube channel as well. So we will be sharing the link. So I request our participants to kindly share the link and spread the information among our groups. Thank you one and all. Have a great. Before closing, Kishore Kumar sir, would you like to say something?
Sorry, Prashant, nothing other than wanted to congratulate Hila on the wonderful work, and hopefully we should use the software to reduce the mortality and morbidity in India in a huge way, because we are one of the very few countries with a very high maternal mortality. So even if we reduce the maternal mortality by 10, that's a saving of a huge number. And the cost of saving such mothers is, it's enormous. So I think such a simple artificial intelligence can make early referral to regional centers, which can save the mother and help a lot of families. There should not be any delay. I think we should start using the private sector, and then we should start using it in the public sector soon. Thank you very much. Back to you.
Thank you. Have a great Sunday evening. We'll catch up again. Yes, Hila, would you like to say something?
Yeah, I'm saying thank you very much, everyone. Thank you, Dr. Kishore, and thank you, Ganesh, for arranging this talk. It was a great pleasure, and thank you, everyone. We are looking forward to collaborating with you all, and for the best of the mothers and the babies in India. Thank you very much.
Thank you. Have a great Sunday evening. We'll catch up next in Tuesday and Sunday again. Bye.